All right. Well, thank you. It's a pleasure to be here. Thank you for the invitation. So I'm going to speak about essentially the use of surgical navigation. I'm going to talk about a variety of different indications, and then, of course, there are many other indications, but this is work that I've been doing. So I did a first navigated surgical procedure in December of 2008, which probably tells you how difficult it is to do this. And the reason it's really difficult is not technical, it's actually financial as a veterinarian. So the system I borrowed was a system from Stryker that was essentially $750,000. And they loaned it to me, and I thought naively, if we do a really good job and we get this in the newspaper, they'll give us one. One of those things was correct. You can imagine which one. So we ended up, and it was difficult because the system was designed for humans, so every time I navigated the knee and I said, this is the size of the femur, the system crashed and said, no, it cannot be the femur because it's tiny. So we had engineers in Kiel in Germany who were reprogramming the software as we operated. So surgery took a long time, but it was absolutely awesome. Okay, so my disclosure. So I founded a company a little while ago that is pretty inactive. It sits in my house, but it is designed to innovate in surgery. So our primary interests are surgical navigation and surgical robotics. And you can imagine the fact that I'm here means I'm probably not pursuing navigation because somebody else is doing it better. But I want to show you my results so you can see why what the navigator does is superior to what we were doing. So, for those of you who do total hip in dogs, you know that the results are generally very, very good. And the primary complication that we face, not necessarily the most devastating, but certainly the most common, is coxofemoral luxation. There are a variety of reasons for that, but they typically relate to abnormal or suboptimal positioning of the acetabular cup and or the relationship with the femoral head. But it's widely known what the risk factors are. It's also known the importance of surgeon experience, and the problem with hip replacements is it's a complex procedure with a steep learning curve that in the dog is 44 dogs. And for many surgeons, 44 is not a number of hips that they do regularly, and it's certainly not a number of hips they do each year. Just as is the case in 50% of human surgeons do less than 10 cases a year, and the human data is that you probably shouldn't have your hip done by those people for obvious reasons. So when you're dealing with acetabular cup orientation, in a well-formed hip that is just dysplastic, then relatively easy to find the point of entry, the center of that cup. But sometimes the actual position of the cup with these luxoid hips and very, very deformed hips may be very difficult, but certainly whether it's normal or abnormal, you need to know what the angulation needs to be. You also need to have a sense of the depth. These are the things we worry about. The current approach for doing that using standard instruments is basically very, very hands-on and very, very surgeon-specific. Positioning of the patient is absolutely critical, and it's also incredibly poorly controlled. We have a variety of techniques that we use. There are some better techniques coming out now with fluoroscopy, but previously we used to sit at the back of the dog, prepared for surgery, putting our fingers on the ischium going, yeah, that looks good. It's not the best. We do it, and it's better than nothing, and it's certainly better than forgetting to do it. For any of you who've ever done that, and you're doing your angle of lateral opening, you go, this is good, and then you take a radiograph and you realize you did a very bad thing. But this is a perfect opportunity for navigation, and so why do we care about that, and what are we trying to do? So you can see here, is there a pointer somewhere floating around? Is there a pointer? Could I borrow one? That would be perfect, thank you very much. Okay, so you can see here on this schematic here that you can have a situation where you are neither accurate nor precise. So the center is the target, the bullseye is the target. So you're all over the place. You can be accurate in that the average value of that shot is in the bullseye, but they're not precise. They're all clustered around nothing. They're just all over the place. You can be really, really, really precise, but completely miss the point. But what we want is to have a really, really accurate day, and we want an accurate day every day. So we want to be accurate and precise, reproducible. Because we know in clinical medicine, just as in life, the weird things happen, the outliers. Okay, so it's the outliers out here that we know, at least in total joint replacement, those are the patients that cause the problem. And problems aren't just a problem for the patient, they're also a financial cost to society. So we want to try and avoid that. And computer-aided orthopedic surgery or computer-assisted surgery, I prefer computer-assisted surgery or navigation. There is a term, computer-assisted orthopedic surgery, but the acronym for that is chaos, which doesn't seem like a great acronym. It's like, bring in the chaos. No, I think not. So we really like the idea of using surgical navigation as the tool, and we think it's going to be important to make us better at what we do, and also, over time, anticipate that it's going to allow us to think about doing procedures differently. We're far from new to this. Neurosurgeons have been doing this a while. They're obviously dealing with things inside a closed box, and it's nice for them to have you don't want large objects going in there, and you certainly don't want people going in there and wobbling instruments around. So it's good that they have navigation. The hip surgeons have got onto it in the human field. So whether you're looking at acetabular alignment, or in this case looking at anteversion of the femoral component, there are ways to do that. And in the knee, then again, you can do the same thing. So I'm aware that Professor Martini is going to talk about the navigator later, so I'm going to try and stay away from too many technical aspects to do with registration. He's just hopefully in deference to the fact that he's going to talk about it. But briefly speaking, the premise here is you have the wise old bird up here looking at you with two eyes, and everything in the field is somehow tracked spatially. And the key thing is you've got to tell the computer system where everything is relative to the three-dimensional space that is your. You can't see the three-dimensional space, but you essentially capture it and characterize it. In human medicine, it's widely known that in both knees and hips, the use of these navigation systems improves the placement of implants. It doesn't necessarily mean, though, that better placement means better outcomes. There are now data showing better outcomes, but it took a long time. First goal and first driver for doing chaos or computer-aided surgery was actually to just do better technically. It wasn't necessarily proven immediately that it made a difference to the patient. So briefly, this is how it is. You've got this an optical tracking system looking at these tracked objects. Each rigid body, in this case a bone, has to have a rigid tracker in it for it to be tracked. And so you've got typically one in the femur, one in the tibia, and then you'll have one on any instrument or guide that you have in. It gets quite complicated, but you can essentially design a workflow that allows you to do that. So this was what we thought would be really fun to do. So back in 2008, we just did it. We just did a clinical case. We thought this would be great. We did that. It went great. We didn't get the piece of kit left. They rapidly removed it. So we were left with nothing. So I went and talked to some engineers, and they made a little piece of software that would do this for us, and we did a system in the dog. So this is our system, tracker in the tibia, tracker in the femur, and then essentially this is what's called image-free navigation. So the way you do this is you use direct point touching of landmarks on the bone, and you don't need that many landmarks. So for example, you need the lowest point on the medial femoral condyle, lowest point on the lateral femoral condyle, the middle of the knee. You need the top of the tibia, so you have the two most extreme margins, medial lateral, you have the intercondylar eminence, you have the distal malleolus, the midline of the distal malleolus, and then you need the hip center, and that's the only one that's really tricky. But actually it turns out that there are very clever principles, and you can actually work that out. So if you put a tracker, you have that rigid tracker on the femur, if you circumduct the dog's hip, then the point of motion of that dog, assuming it's not got a luxated hip and no round ligament, the center of that rotational point is the center of the hip. So you don't need to expose the hip, you just need to define the circumduction axis of the dog. So if you do that, you get essentially, you don't get a beautiful anatomic map of the femur, but you get enough to know what the various axes are, and now we're just going to be cutting across axes. So we know what the surgery is, we're going to be orthogonal to that plane, etc. So we can do that. And if you do that, so I had these surgeries done by one of my students who's a fourth-year student in Ohio. This was a while back now, so I guess 2015 we did this and published it in VetSurg. What she showed was that if you just have her do regular surgery, so she got 3 practice surgeries with me, and then we did cadavers. And so she did pretty well. She as well as most of the surgeons who come to our knee course. But what she did was much better when she navigated. And so what we found was in this case, in this plane here, which is the varus valgus, the frontal plane. That's the plane that's the most dangerous to get wrong because it has the most implications for laxity. She really did well. She got it down, the median came down, the mid value, but also the distribution came down. In this one here, which is the slope of a tibial component is actually defined by the instrumentation. So we do a pretty good job with that, of getting that around 6 degrees. We weren't expecting that really to be that different. But what she did was got much more precise, she got much more reproducible. So it worked. So we were very excited. And again, we kept looking for somebody to give us a free system, but they didn't. So we carried on. So then we started doing some stuff. This is now when I got to Cambridge. We started working on TPLO, and again, using a very basic system. You don't need anything fancy to do this. We had a very simple system like this. This circle defined your optimal position. This one defined your optimal direction. And this was perfect. And so you basically move your hands until these all co-align. And when you do that, you find that you can improve TPLO fragment positioning, particularly in the frontal plane. Others in parallel, and in some cases before, although I don't think I realized it at the time, were doing work in horses, again with navigation, particularly for screw placement. Some really interesting work coming out of that, again using, in their case, a stealth system, so a commercial system that somebody did leave for them. They didn't take it away at the end of the procedure. It's a big shame. So anyway, what I wanted to show you was some more recent work. So this is fairly recent data. Some of it started a while ago, but we've just sort of been mining the data. And this is to do with surgical navigation in the context of acetabular and hip replacement. This happened well before I bumped into Imaginalis at a booth somewhere. So this was already happening, so just so to put some context. But when you see how we did it, you'll realize why we like the navigator. So we CT scanned 10 medium to large breed dogs, got DICOM outputs, put them in through Mimics and built a 3D model using 3matic as usual. And we published on this in terms of how you define the measurements. There's a Vet Surge paper, I think, from a couple of years ago where we defined the measurement axes for defining version and ALOs in dogs using 3T morphometry. We printed all of these in a series of bone models. So we made 30 bone models using a novel wood polymer composite that actually reams really nicely. Most, for those of you who have used them, most of the ABS or even PLA plastic, when you get reaming on it, will melt or try to, depending on your fill density. This stuff behaves really nicely, and actually it sort of behaves a little bit like wood, but it's just kinder on your instruments. We designed a jig system like this. So what I did was every pelvis, I essentially designed a central axis across the LS that went centrally through the LS and then created that as a whole. And then we basically then put that on rather like a spit. We just lowered the pelvis onto that so it's completely perfectly positioned. Again, do not do this in your clinical patients. This is very invasive, all right? But it is perfect. They are beautifully aligned, but it's awkward to explain to the owner why there's that extra clip space. So this is what we did, and then we zip tied it, very technical, to make it really rigid. And then we have a beautiful system. So now we are just testing the navigator, not a wobbly fixture and not our inability to get the thing in perfect positioning. And we compared 3 treatment groups: freehand, standard surgery; image-guided navigation, i.e. CT-based, and again, I'll let Professor Martini talk about that in his talk, and then image-free, which is where you navigate using fiducial points that you touch on the pelvis. So in our case, we touched the ischial tuberosity bilaterally, the ilial wing bilaterally, and then we marked the ventral acetabular rim, all of which are points you can actually access surgically during a standard hip replacement. The surgeries are all done by somebody who was so it was done by a single surgeon. She was residency trained, non-diplomate, and the goal of that was that she wasn't too involved in having, as it were, her own way of doing things. So this was a fair test, and she did all of these procedures with guidance. We use standard total hip instrumentation from Biometrics. We use standard cups, BFX cups. We had CT DICOM models of all of the, or STLs of all of the cups, all of the instruments, so we could actually define it all. And everything was done exactly as we would do it normally for the freehand. And then the only differences in the procedures you'll see were because of navigation. So this is the standard approach. So this is hopefully going to play. So that's me reaming. This is practice 1. Don't worry. So this is just us reaming acetabulum in the jig. It's not doing too much. These ones, the freehand ones, were not instrumented for tracking. We didn't bother. You can see the central point here, holding this thing in perfect vertical, and the zip tie down here. Standard instrument, standard reamer, standard positioner, alignment guide, a standard impactor. And then for the navigated ones, again, we bring in the navigation system here, which is a Polaris Vicra system. We have our software down here, which is all homemade. This was designed by, I basically had a PhD student at UCL write some code to allow us to work through Slicer to give us this. So it was all very cheap and cheerful. Cheap being the most important word in that sentence. Here's our patient. We have trackers on the impactor, trackers on the drill, all homemade in terms of the fixturing. This shows you how crude it is, I think. So what you have here, and I'm going to purposely move this around so that you can see it, but this is what it looks like. Green is the perfect axis, grey is essentially the reamer axis. And so that's side view and that's top view. The goal of the game here, and it's just a video game, is to keep the green dot centered within the axis, through the center of that tube. When you get off, you need to adjust. So we'll see it, and I purposely, it isn't me being rubbish, I actually just purposely do this. If the video had sound, I turn the sound off, but it would say, move your hands. So that's what I'm doing, okay, just to show the fact that you can tell the difference when you're on and off axis. So, okay, you basically move it. It's not very much, but you can see I'm moving out now, so you can't see green. Then you come back until you can see green, etc. So it's super crude. So just so you know, just before we see the results. And then we measured essentially, for all of these things, we use the standard published system, the published protocol for doing this. We measure acetabular angle of lateral opening and acetabular version, and we do that on the native acetabulum because that reflects what we were trying for, and then we have the implantation angle. Just again, in terms of clinical relevance, these are medium-sized dogs, so 5 males, 5 females, relevant breeds, and relevant sizes of cut. If you look at the data, so here is the control data. This is freehand. What you notice is obviously the value is higher, but there's also a lot of variability. These are the navigated, and although they're arguably better, they're not statistically significantly better. All right, and there's a variety of reasons for that we'll talk about. Similarly with the version angle. So we were really disappointed when we got these. We thought, this is ridiculous. It works so well in the knee, and it works so well. Well, there's a reason for that, so we'll come on to that in a minute. But what it did do, empirically, is reduce these values, i.e. reduce the error from what you were trying to do. You were doing it better. But you weren't doing it particularly reproducibly, and because of that, your statistical significance with here an N of between 8 and 10 was quite hard, and 8 and 10 is quite a lot of samples. So what we got in our results was similar cut positioning despite our technique, and we reject then our hypothesis. There is no apparent statistically significant benefit to navigation. There are some other benefits that are nothing to do with statistics, including the fact that the navigated approach just in of itself, particularly with an image-guided one, does allow you to completely correct for any abnormality in the position of the patient, so you don't have to put them on a spit, which is enormously beneficial. You actually know where the pelvis is, and you know where it is in surgery. We've all been in situations with the hip positioning guide, and you're doing something, and then something moves, and you think, I'm sure something's moved, but I can't quantify it, and I can't fiddle it because we've now got an open hip. So is there really no benefit to navigation in the patients we're dealing with? Did it really fail where it's worked in other systems and it works in humans? Why did it fail? There were lots of limitations with any study like this. These were not dysplastic joints. We weeded out dysplastic joints because we wanted to try and make something easy indeed. But these were isolated plastic models. And so the reality is in this, you don't operate on isolated plastic models, and you certainly don't get visual input like you get when you have a pelvic model sitting on a stand. And so the reality is what we should have done is taken the hip and put a whole bunch of silicone over it, made an incision through it, and given ourselves a relevant thing. That's not what we did because we wanted to have a standardized model system, but that's what we did. So what we've effectively shown is that if you navigate, now when we did navigation, we only looked at the computer screen. We did not use any other visual landmarking, we just looked at the screen. So what our study doesn't show is a statistically significant effect. What it does show is that if you don't look at the patient and can't look at the patient, navigation works as well as having that patient filleted and exposed completely, which is pretty good. So that's what this shows. It shows that two things. So firstly, don't do a study like that again. Secondly, it really is, you can effectively not look at the patient's anatomy, you only need to follow the navigated guidance and you will get it as good as if the patient was just an exposed specimen, which is pretty amazing. It is always as well important to understand that navigation in human fields has not always been shown to be statistically significantly better than a really experienced surgeon. Again, particularly if you're looking at individual cases. Experienced surgeons do two things. They do the procedure technically well, and they tend to have less bad days. So they are accurate and precise. They are not a great comparator group. That's not who you're going to sell it to necessarily. Where it's got enormous potential is in the training of people to get to that level of technical excellence with a safety net, and in the routine use so that you can have a good day every day. If you do a power analysis based on our data, based on the exposed bone specimen, you need between 20 and 74 samples per group to demonstrate that with power of 80% and a p-value of 0.05. Most people are not going to do that study, including, unfortunately, us. So you need realistic models. Of course, what you really want to do is just go to cadavers, but we've historically always gone through this process. But certainly as you move forward, doing plastic models in of themselves without some sort of shrouding makes it's a very scientifically clever study, but it's not very clinically relevant, and it makes navigation look less good than it is. So, in conclusion, accurate positioning of the acetabular cup using surgical navigation is entirely possible. Without using visual cues, navigation is as effective as freehand reaming and impacting, which again is pretty remarkable. So in other words, the patient's completely closed, but you can effectively get the same results as if you'd got them as an anatomic structure. We use the ventral acetabular rim as a landmarking system, and when we do that, you can get really good and really predictable impaction of and positioning of the acetabular cup. So, I guess this sort of closes it out. Next step. So, one of the things you saw is there's a clear and present need for slightly better graphical interface, and of course that's why the navigator that's available is so superior, because you've got a much better graphical interface, amongst other things. Bear in mind that system is designed for image-based tracking. So you've got a tracker on that patient, and you're using that, and you're registering that tracker in the virtual space against the tracker in the physical space. And again, Prof. Martini will talk about that. So it's not quite the same as what we were doing. But what we need to do now is actually, from the ground up, go through a systematic process of assessing the accuracy, precision of these systems, or this system, in different indications to define what its accuracy is and its reproducibility. You will then have to look at clinical performance, evaluate that, look at utility, ease of use, adoption by surgeons, and critically cost effectiveness. You can't afford these days to just have a nice toy, despite how much we like nice toys. And then I think over time, as it's adopted, I think it's going to be a case of getting key opinion leaders to think creatively about new indications for this new technology. So the fact that, if you think about it, if you can define the point of entry and the trajectory of a drill, of a reamer, of a saw blade, then realistically, all other things being equal, you can really do things through a very creative approach. We often don't operate through the back of the knee, back of the stifle, because there's a lot of electrical and plumbing at the back. But you can reimagine doing things differently if you could navigate things and combine navigation MIS. So, and again, with the depth capabilities and real-time tracking in time on the screen, you can really think creatively about doing new surgeries in new ways, using approaches perhaps we've been scared to use because of the attendant risks. So with that, I'll the work we did was funded from ECVS. Claudia Zindel did all of the surgeries, Zach Baum did the programming, and I can't go without mentioning our very friendly radiology referral person who allowed us to bring bits of dogs in at strange hours and didn't scream. But turns out she likes wine and chocolate, so big win. So anyway, thank you for your time. I'm happy to take any questions if there are any, other than why did you do that? Any questions? Oh, yep.
So, really fantastic. Thank you.
Thank you very much.
There is another difference in the real surgery. The pet is not stable during reaming. You can have a little bit of movement, and I think that this can be a big influence in reaming direction and
absolutely
influence.
Yeah, absolutely. So what I didn't show was too much active video from that. We got crazy actually when Eva came over with the navigator. We started looking at that. One of the problems is it's almost too sensitive. You're reaming and the thing is just going and just vibrating, and it's almost like I need less sampling speed. But it does allow you to navigate in real time, and it is, I mean, it's a bit of a derived skill, I think. But you're exactly right. But imagine if this is happening, it's moving, and then over time it's moving away from you, and you just are standing there going, this is 20 degrees, this is 45, it was 45 degrees, it's not 45 anymore. The other thing is, as we've done more studies on dogs, is where does 45 and 20 come from? It comes from here in the sky somewhere. And it's a good average, but if you're getting to a point where if you're going to go to the trouble of navigating, why would you navigate to an average? Maybe we should be thinking about navigating to the dog. And if you have the data and you can do the pre-op plan, if we know we can get 3 degrees of the plan, and the plan says it's 17 degrees, if you just say, I'm going to do 20, you're already 3 degrees out. Maybe that doesn't matter. I don't know. But if the goal is for all of us to be better, I mean, for me, when we thought about selling a navigator back in the naive days when I thought we would actually better make one, we thought about who would buy it. And initially, it'll be early adopters, people who want to get better. And some of those are the really, really good surgeons who just want to be better. But then eventually, what's going to drive sales is going to be a client coming in and saying, I heard my friend had a dog done with a navigator. Why do you think you're good enough to not use that? And it's going to be a very difficult situation to actually think that you're going to be better than the navigator, as long as the data are there. So for me, that's where this is going. But you're exactly right. It gives you almost too much information, so we have to filter it out and figure out. But critically, it establishes a much, much better safety envelope for us to operate within. And that's what I care about. So, all right, you're very welcome.